Evening, everyone. Welcome to our NAMI Tri-Valley monthly general meeting where we bring a special guest. And this month we are really honored with a very special guest, Dr. Tribble, who really doesn't need introduction, but I'm going to introduce her anyways because we love having her year after year. But before we get started, I want to just quickly give you an update of what's coming next couple of months. This is second half of the year where we have great lineup of the speakers, and today we're gonna speak with or hear from Dr. Tribble. September we have a special coverage on housing, and our own Kim Curtis, who runs the Goodness Village, to come up, give us an update on what's happening on the housing front and what they've been up to, and in general, what's going on with the housing. Then October, that's by the way, is September 8. October 13, we have Nisha Beckton, another dynamo who runs the Chief Executive Officer of Pathways to Wellness. If anybody knows mental illness, it's Nisha. From medical side to the business to the community, she brings it all together. So that's always a great way to, I tell you, as we end the year. And then November 10, we bring in Dr. Kostelnik, our own Asked the Doctor, and I've been doing this over 12 years, and he's been coming here from the first year with Marcia. So we're really honored and blessed. Like I said to Dr. Tribble earlier, we keep ourselves educated. We ask questions. We're here to support the families and our community at large. I'm not sure I introduced myself. For those of you who don't know, my name is Armine Matensian. I am the second vice president. Like to think of myself as Marcia McGuinness's right hand, who is our president. You see her right there, smiling in blue shirt. Okay, so there's always a lot we can say with what we do, but I think given this small group, I want to turn the floor back to Dr. Tribble. And let me start with a quick introduction. For those of you who don't know Dr. Tribble, her records speaks for herself, her accomplishments and what she's done for Alameda County. She's not a newcomer to us, and we're honored to say that she's always finds the time for us. And even when she had to drive, okay, post-COVID, we do Zoom. It's convenient for all of us, but still we get the information. So Dr. Tribble has over 25 years of practice in a behavioral health field and is an experienced and dynamic administrator. Over her career, Dr. Tribble has held a number of leadership roles in California and on the East Coast. She currently serves as the Director of Behavioral Health Care Services for the County of Alameda and formerly held the position of Chief Administrative Officer of Behavioral Health Services for a large East Bay public health system. She has served in executive leadership in organizations providing crisis and acute behavioral health services, consultation to individuals and families, schools and organizations, forensic services, integrated primary care, and previously managed mental health services in cities of Berkeley and Albany. Dr. Tribble is a published researcher with several publications. I won't go into it just to get to her actually faster, and holds a Bachelor of Science degree in psychology from Howard University. She also has a master's degree in social services, specializing in practice with individuals, families, and groups from Bryn Mawr College in Bryn Mawr, Pennsylvania. A master's degree in clinical psychology from a Philadelphia College of Osteopathic Medicine, and a Doctor of Psychology degree in clinical psychology from a Philadelphia College of Osteopathic Medicine. She is also a licensed clinical social worker and in the state of California. So I'd just like to add my own. She's a dynamic speaker, and we had her here year after year. So what I would like to do is turn the floor to her. please um, have your questions ready. If you think of anything you want to ask, feel free to type it. We'll read it out loud. But this is a small group. Raise your hand, jump in. Let us know that you want to ask a question. Okay? So, without the further ado, I am going to turn the floor to Dr. Tribble.
Thank you so much for the introduction. It's humbling, and I certainly appreciate it. I've got a few family members that would just call me mom, so you all can't call me that, but I appreciate it. So it's a pleasure and a blessing to hear. Um, it's been a long journey. So I want to be respectful. Should I share my slides, or will they be shared? What's preferred? Either one
Yes,
is
please. If
okay.
you can share,
Okay.
I think you should have permission to share.
Yes, so I will share.
So those of
And
us attending, she will send us the slides and we will share it on our website. Okay, for those, she may or may not go through all of the material, but it's there for us.
thank you. So I want to confirm, can you all see my slide deck?
Yes.
Okay, wonderful, wonderful. So I do have, I know there's often questions about specific to Nami Tri-Valley. I do have some information available at my disposal if there are questions later, but for now, I will just give you a high level and some deep dive. There's a lot that's been happening since the last we spoke, so I wanted to make sure Tri-Valley is in the know. Okay, so I'm going to start with our budget. Sometimes that's less interesting, but it's important because there's some nuances that are important to have, and our departmental structure and operations as well. So this remains unchanged. And so if you think of our systems of care, this is often something that's helpful to people to know is my office, as well as the strategic initiatives, a lot of which you'll hear today, responsible for, and there's accountability. And then you'll see clinical operations. That's literally all the systems of care with the exception of crisis. So you have adult, child, young adult, transitional age youth, access is there. There's an update that I want to share with respect to how people get into our system. And so that's where clinical operations is. Office of the Medical Director, it used to be Dr. Aaron Chapman. We will miss him greatly. He's our Chief Medical Officer, but crisis services is there. Nursing services, pharmacy. We have our own formulary as well as a lot of really important work that we do in the community, integrated our federally qualified health center, that work, integration with our hospitals, that's there. Office of Health Equity, obviously, we're an HMO to party, to mental health as well as substance use, but it makes sure that we're always tracking outcomes, looking into making sure that we are advocating not just on a racial basis, but as far as services across the county, linguistically, who's receiving them, what's the quality of care. So really that's what the Office of Health Equity is. And then plan administration, that's our finance, Behavioral Health Services Act, our quality assurance, data analytics. It's really the backbone and infrastructure of the department. So that's really how to see it in terms of the high level. These are our leaders. I always tell them you can't hide once you're in public service. The public should see and know who you are. As you can see, I want to acknowledge the vacant place that we used to have with Dr. Chapman. So again, we miss him greatly. He's our Chief Medical Officer. But you can look later if you'd like to connect names to faces. Some of these images are a little dated, but some are mostly up to date. So you should still recognize them if you'd ever like to connect.
Mm.
And this breakdown, again, this is for future reference. This further outlines what I was mentioning in terms of the systems of care. And again, it very much mirrors what you saw before in terms of the clinical operations, Office of the Medical Director, there's a health equity division, plan administration, that it also shows by level. So again, Deputy Director James Wagner, who I know some of you know, is the senior most executive leader in terms of clinical operations. We're hiring now for a replacement for our chief medical officer, which is Dr. Chapman's position, and Deputy Director Vanessa Baker is over the plan administration. But again, if you were ever interested, you can really clearly see what is where and who is what. And I think over the years, things have evolved. All of this, if you see the circle at the top, That is through the broader agency. All of those functions used to be within our department. Now they have been moved out, and the oversight is elsewhere within the agency. We still fund and pay for them, but the those activities are now outside of us, and within and outside of our sphere of accountability.
Where would John
Yes.
George fit in that picture, if I may ask? I'm just curious.
Oh, that's a great question. Well, since in 1998, since the county separated from the Alameda County Medical Center, which are the hospitals, we're technically cousins. The funding of John George does come from us. So at this point, I believe last year we paid them about $91 million for services at John George. We also have some contracts in their primary, in their outpatient services for substance use. And so if you look on our clinical operations, it depends what the activity is. If we're talking about long-term care, like people who are on the inpatient unit, clinical operations is there because it may be a person who's been in John George for a few weeks. They may be being transitioned to older adult or adult services. So that's when that system will kick in. If they're just coming through the ER, like their PES, the psychiatric emergency service, crisis would be there often. They are interfacing because they're interfacing with ambulances, communities. So, if they get to their quote ER, that's really crisis. But once they're admitted, they have longer term care and support that goes through any of our clinical ops teams.
And where does Villa Fairmont fit in? What's the relationship with Villa Fairmont?
That is ours. So with the exception of Alameda Health System, which includes John George and like Highland Hospital, as I mentioned, we're cousins. So now the board delegated authority to their own board of trustees. So the county may fund them, but Villa Fairmont, however, is still a county operated or owned. We operate it, we contract out with providers. That falls under adult and elder adult system. For like Willow Rock, which is for youth, that falls under children and youth system of care under clinical operations. So just Alameda Health System and those safety net hospitals, that's what it was like when it broke apart, remain under Alameda Health System, and we fund them in some degree, but the rest are under county, either us or some of the contracted providers that we contract with.
Okay.
Okay, so this is essentially, if you're interested to kind of get a sense of who does what, this should help you navigate. So in terms of our budget, last year's budget was 832 approximately million dollars. It will go up. However, there's some caveats. It is now, as of July 1st of this year, $844 million is my budget. There's a $12 million increase. And it's important to note that, as I'll talk a little bit about later, but as you're aware, there was Prop 1, which was the Mental Health Services Act, and that transition to Behavioral Health Services Act, which started July 1st. Our budget is large, but we couldn't afford to pay, given that for about a $76 million delta is what we had, in addition to the elimination of about $26 million of prevention services. So a lot of activities were and advocacy happened, and Measure W was used in part. The way that the agency, there's new leadership, it didn't come directly back to us. It actually went to other parts of our agency. And so we are just essentially the holder of the contracts while the other parts of the agency decide how they'd like to administer. And so there was some risky funding that happened. Unfortunately, there were some commitments made at the agency, but that we had to step in to help support, given I just want to praise our leadership and the way we have handled finances. So we had to step in. So if you look at $19.8 million of Measure W, that's what really came to our department one time. And $7.7 million, the agency determined that they would liquidate our contract. So we hold money because the state is often late sometimes in providing reimbursement. And so we will make sure that we keep our contractors paid. So we still have money in those accounts, and we're ready for when those bills come due, or if the state garnishes. This is it's not the correct word, but for all intents and purposes, they garnish some of the payments. So that was liquidated, $7 million. That's very risky. We don't typically do that. That is what contributed to some of the 1 year's allocation. So it does mean when those bills come due, we will have to get it some way. So we will likely have to go back to the board to ask for money. So that was a kind of a strategy that our new agency leadership used. And so it also shows there are some contributions from the agency itself, Healthy Schools, so they will continue to administer those funds. Bridge Housing Grant, what would be paying for some of those things. Again, that's the housing and homeless services, not within our department. And so we also used about 16.5 and 2.6 respectively of realignment dollars, which just means money that's categorical to behavioral health. And in parentheses, very risky for us to do this because essentially we did absorb a lot of those cuts in our own budget. And so it meant basically we are slightly increasing our estimate of what we'll be able to bill or get back from the state. Always risky when you have HR1 and you have cuts to Medi-Cal. So, but again, this was the approach that was used to our agency. And so obviously, because these are one time and there was not a permanent increase, our budget will go down significantly in the next fiscal year because of all these one time. It was just not all allocated to the department permanently, unfortunately. And that also does mean the services will have to discontinue next July 1st unless there's other intervention.
Well, a quick question?
Sure.
This big sum number, right? What is the number of population that we support in Alameda County? Just to put things in perspective, has there been an increase in population? Is it flat? And what percentage is mental illness that we're trying to serve?
So we serve on a regular caseload quote, meaning ongoing contacts with community members who are part of either our or CBO partnerships between mental health and substance use. There's about 25 to 30,000 beneficiaries in Alameda County that are receiving services. That does not count, for example, people who maybe come through the crisis system, who don't have a long-standing relationship. We have lots of programs that if it doesn't matter if you have homework or, excuse me, Medi-Cal or not, our crisis will respond to you, and then we will refer you back to Kaiser, for example. So I'm not counting those who don't remain on our county caseload. So anywhere between 25 and 30,000. Are we seeing a decrease? Slightly, and we project to see more. And what it's looking like, because again, a lot of the federal policies are only now starting. We're seeing less utilization. Our providers are concerned because they're not able to bill as much just because the Medi-Cal availability is not there. And there's a concern that we'll really see a decrease in January when those people are no longer covered by Medi-Cal. That's really the revenue because it's safety net that we use to cover the expenses for operating. So, and then on the other hand, though we've seen a slight decrease, slowly but surely, we're seeing an increase in, I'll say, how do I say this? In the experience of a person. So they're more severe issues that people are dealing with. So although we may see, this is just as an example, one previous year we may have seen 10 people, now we're seeing 7, and those 7 are much more ill, quote, than they've been. So their stays are longer. They even may have more interactions with the justice system, go to jail. It's just more serious that people are experiencing, and that's across the board. That's statewide, even nationwide. Sadly, it's not unusual, and there's a lot of potential reasons for that. And so
Thank you.
so that's really the structure of our department, our budget, and where we are at this point. So, oops,
Hi, Doctor.
yes, of course.
This is Margaret. Can you explain a little bit in detail that 1 million to schools and then trust funds?
Yes, I will do that.
What is that about?
So a way to describe it is if this is really around the reduction around Prop 1. So Prop 1 threatened to cut our department
So,
budget.
excuse me 1 second. Margaret, can you mute yourself because that echo will
Oh,
go away? But
I sure will.
thank you.
Okay, and thank you for that. I thought it was me, so I didn't I didn't want to do anything to hang up on accident. So in short, our department was facing $75 million of cuts because of Prop 1. What we ended up doing is tried to reduce contracts as much as we could, and then we did some cost savings. We gave up county positions, and we found one-time revenue to help, and we got down to about 30 some million dollars of that. And what there was advocacy, and the board did absolutely want to support that bridge, for example, for one time. And there was an alternative strategy. So instead of purely plugging that one time hole with Measure W, alternatively, these are where some of those sources came from. And so they don't all add up, but these are just getting an idea of where we're now in a more of a risky place. So that 1.1 million healthy schools is, so essentially we fund a lot of the school-based services, obviously, for people who have severe mental illness. We also fund, it is operated out of agency, a school-based consultation and treatment and things that are happening in their and through the agency that they work, and they have partnerships with the school-based. So in addressing the Prop 1 gaps, their trust funds had dollars in it, so they contributed 1.1 million to salvage programs that had previously been funded by us. So it shows you the source of it. Just like the Bridge Housing Grant, they the we receive those dollars, but that's what we're showing you. That's the source of those dollars, and these are just new kind of updates. And again, 16.5 and 2.6 million dollars of the 844 million are based on us being more aggressive with saying we're going to get revenue. Again, this is all that we had available to us, given that we were actually having to liquidate our own assets and such to pay for some of those gaps. So these are just examples. I know you just asked for the one, but these are examples we just wanted to be transparent with on what is making up our 844 million. And because of that, next fiscal year, unless something increases at the state, it's going to significantly decrease in our ability to fund programs. So I hope that
So
answers your
year over
question.
year, how far did it go down? You said last year was 834, 830.
832, you see there,
Uh-huh.
and it should have gone down. 832 minus about 35 million, and eventually another 40 million, because again, we found one-time revenue to address
Okay.
that 75 million. However, a lot of strategies were used to plug the hole, but most of the strategies that were used won't sustain us next fiscal year. It was just a temporary process. And as I said, part of those gaps we plugged by saying we will have more revenue, maybe we will bill more. This is a hope and a prayer, very risky endeavor, but given that no ongoing permanent funding was allocated to us, these were our options that were only available to us. So that's what that means.
Okay.
And
Thank you.
and usually year over year we increase our budget. So since I've been here, I think we've gone from about a 300 million, $400 million budget, about 300 million to what you see now. I don't know that we'll be able to sustain that at this point. And so again, that's why I
And that
praise.
also includes a lot of population growth, right? Alameda County has the
That's
numbers been
exactly
increasing.
right. That's exactly right. Some of our billing strategies helped, some of our restructuring, as well as, unfortunately, more people need service. So we can serve them more, which is great. So our budget will increase. So a lot of different things contributed to that. We've done some things that help our providers bill more. They see more patients and clients. Sadly, though, that's reflective of the growing need, though. So as we grow, it's because the county grows in need. Um, so as we move forward, I just wanted to spend just a little bit of time to give you an update in terms of some of the initiatives. This is something that I always like to remind folks. When the pandemic hit, it was a determination that I made that we had to stay focused because I was one of many. I think you mentioned the pandemic and having to drive places. We did not shut down, and I only started working virtually about 2 years now. So we were still going to work in person. We were still doing this because we are an emergency safety net required service. So I developed a strategy on how we would do things to make sure we move forward. We developed True North pillars, and then some system level goals and accountability measures to keep us focused. There was just a lot happening all at once. So that's essentially what that is. We also did a strategic plan, which I hope many of you remember. It feels like forever ago. And it took us 2 years because of the pandemic and such. And we gathered a lot of information. And then we translated and disseminated that information in phase one. Phase two is nearly complete, where we had analyzing all of the new legislative processes, looking at our progress, and we've developed some dashboards that we hope to be public facing. So the public, as well as our department and leaders, can look and see where we are with our process, our progress, and things like that. And then phase three will be at the point of making sure we track our quality and such. And so again, I just mentioned this because I think that's been very helpful to help us be successful in a lot of our initiatives in the county. Nowhere's perfect, but I feel that Alameda County really should be proud of the work and the advocacy and the partnership, even with many of you, to help us get to the point we're at. This is just a highlight maybe for future reflection of what the strategic plan actually said for us to do. And we've been working on that over the last several years. So even though we had to pivot because of all of the changes and laws that were coming all at once, we still put into place a lot of these changes, which I'll highlight in a moment. So this is just, if people are interested, what did that strategic plan say that we would do? And it's highlighted, and if you were able to click on this as you receive later, it actually goes to a link to our strategic plan so people can refresh if they're interested. There's a few links in this document. This, I will not go through everything, but
So you realize, I'm so sorry to interrupt, but we're seeing the financial, the approved budget. Okay, that's the page we're seeing. I think you're presenting other stuff, but we're stuck on
I
the
think we're on a
financials.
new slide.
okay.
Yeah.
Oh, thank you so much. Let's see. Are you seeing it now?
Yes, phase one,
Okay.
phase two.
All
Okay,
right,
now
great.
we caught up.
Wonderful. Okay, this is just what I was describing. Thank you for telling me it was paused. So this was again those areas that I mentioned. This is our guidepost. This what helps us to stay focused. Whenever we launch an initiative, I will ask a leader, does it fit within our True North pillars? If it does not, we have to leave it aside because we've got just so much to do. And then this was that I was talking about the phases of our strategic plan and where we're headed now. So pretty soon the public will, we hope in the next several weeks, a few months, have dashboards that people can look at and see where we are with the process and the progress. And then this was the slide that I was referencing, is a snapshot and a summary of what was in the strategic plan. And here, I don't know if you can see I'm moving my cursor, but I can't tell what you can see. I don't know if you
Yeah,
can
we
see
can
this or
see it.
not. Okay, good. So at the top, that's the link to the full strategic plan people are interested in. It's on our website and it's translated, so people can certainly send that and as you're able. And I was just working up to acknowledge the tremendous amount of change that the system has had. Nearly every single one of these are based in law, new legislation, new requirements that have been happening just all at once. Again, that's why I mentioned for the pandemic, our department nor the state slept, and not that anyone else did, but it was just so much to do. CalAIM essentially was changing the way Medi-Cal was. and is distributed. We have new programs launched. It's called No Wrong Door. We've integrated a lot more with healthcare. You already know about Proposition 1, that's BHSA. Care Court, which I'll talk a little bit about later, we launched that as well, and really have done exceptionally well in terms of how the state sees that process. The opioid settlement, we have about $81 million we've used over the last few years, portions of that was dedicated to Alameda County to help fight this opioid process. And we've done a lot of work and launched programs during this time. Our strategic planning, I just mentioned. I don't know if you all are familiar with Epic, but we have we saved, I think I dedicated $35 million to, it was for us, but it will now pay for the entire agency that we're in to have Epic. And Epic, if you, I don't know if you're a Kaiser, don't have to tell me, but Kaiser has the ability where you can go in and look up your medical record as well as treating providers. It's the same thing. They use Epic as well. So we dedicated that. Our agency has let us know they'll require an additional 29. So that's something we also have had to set aside to give to our agency so that they can help the system. So that will be huge because it will help coordinate care, because Alameda Health System, i.e. John George, uses Epic. Many different hospitals in the county use Epic. So this will shut down tremendously the loopholes where people felt like a person showed up in the ED, or people, they didn't know who they could call. They didn't know if they were our client in the county or wherever, but it really will help the system. So I'm very proud of that. So as I mentioned before, we no longer oversee our IS or IT, but the agency is overseeing that implementation, but that's another huge one. There's a lot of new laws. I won't go through them if anyone's interested, but LaFonza Gibbs is our executive leader over the children and youth system of care. But there's been a lot of changes, social services to foster care. It used to be if a person was in foster care, a young person, and they moved to another county, the new county would take responsibility for that youth's care. The new laws said that the originating county, so Alameda County youth, even if they move anywhere else in the state, we're responsible for them. So there's just a lot of different things. So that's an example. We're still working on our peer certification for the county, but nearly 200 people we've paid for in the system to become peer specialists, which is very important to affirm people with lived experience or family members with lived experience to help work in our system. And that will help us, we think, especially when there's employment impacts to HR1, you lose your Medi-Cal, they may want you to work, and we hope that that pre-work will help people find landing spots. We have SB 43, which I'll talk about a little bit later, that changed the law for 5150 criteria. We launched that, started in January of this year. We are building and have begun to finalize many different capital projects. We've got about $177 million blessing from the state to build facilities in this county, and we are building them, and I will give a little update on those. And we also got for our housing partners within the agency $123 million in capital grants that they were also building new housing resources. Our forensic system, the work at John George, at Santa Rita Jail, at the juvenile justice system, are things that we also have been working on these last several years. A lot of health equity initiatives, and even still, we are working through and making great progress. The county itself, Alameda, was involved in a lawsuit, and so we were called to make sure we make some really important changes. And so that's what we also have been doing these last several months. This is probably more impactful if you saw where we started. And we started with a lot of red. And so now a lot of these initiatives, as you see, are in the green. Doesn't mean they're done, but this is essentially for those really high stakes projects and initiatives, this is where we are, and it's color coded. And we plan to use this kind of stoplight report for the public to just follow. Are you on track, or what's happening, and what's the progress like? So that's something people can take a look at more specifically if you're interested. We have a really good announcement. We sent some information out. Not sure if you were on some of the distribution lists, but is anyone familiar with Access? Access, I should say. So Access, oh, my slides beat me to it. Oh, well, maybe it's cue to my, I'm going to push pause for a second. Access, as of October 1st, is changing its names to First Step, essentially the first name, Behavioral Health Connection, Screening, and Referral. It is now going to be integrated. Before, we had people who had substance use issue. We were using an organization called Centerpoint, a great partner of ours, but it was just not effective to really help people not have to share their story twice. And when a person's ready to get treatment, they don't want to share their story twice. So, and we really wanted to stay current with the law and help it be more integrated. So it's going to be the same phone number, and they'll have mental health specialists, but they'll triage people, mental health issue or substance use issue. And that will start and begin October 1st. So you may see information, access will be gone, but First Step begins, because we also have worked to station our access employees in the community, which is new. That's what we've been doing in the last year. That had never happened. It was just a straight call center. So now we actually have some community-based individuals. Unfortunately, we expect that with people losing Medi-Cal, with homelessness increasing, and as I said before, the issues for severe mental illness and substance use are getting worse. So as much as this is wonderful, we anticipate the need is still going to be huge. And then the resources and providers that can help us support individuals are finite. So we're going to continue to monitor what's happening. But again, that's October 1st. I mentioned SB 43. And that, again, was the law that changed the criteria for 5150. So I don't know if you all recall this. This was very significant, that I believe I mentioned in my last presentation. It started January 1st. And our board, it was 8 hours. I and others testified in front of our board of supervisors, and they did agree to allow us 2 years delay to implement, to make sure that we don't expand the criteria without the system being ready and without having sufficient training. So in short, people may be familiar, you can place a person on a 5150 if they're a danger to self, if they're a danger to others, or if there's grave disability, meaning by virtue of their mental health condition, they cannot provide further food, clothing, and shelter. SB 43 expanded that, was the first time since the 60s, and it said grave disability could also include people who are unable to care for their basic needs because of a severe substance use issue, or they have a mental health issue, or if they cannot take care of their basic needs. So if they're in a hospital, for example, and they have a gangrenous wound, and they are also suffering from schizophrenia, but they refuse treatment, SB 43 allows person to be placed on a 5150 because their mental health issue is precluding them from taking care of themselves. So that's essentially the crux of it. And so that began in January. We did a lot of different activities before that and got approvals from our board to do the work that needed to be done. Specifically, this is kind of a high level activity on the things that we were working on. Here's SB 43, which changes, again, 5150 law. And I keep mentioning 5150. It did not affect children and youth, people under 18. That is actually not a 5150, that's a 5585. So it's just for adults that the law changed. But what we also did, we noted that Alameda County was operating inconsistent from the rest of the state. And what I mean is, the law gives the authority of whomever is in my position, happens to be me for this county, to designate people, basically deputize people to help 5150s and do that work. Um, and Alameda County, for whatever reason, had changed the process from the law, and it required them to go to the Board of Supervisors. So in preparation for this, we realigned it. We did have emergency ability to do this, like the law says, back when COVID hit, but that expired when COVID was ended. So we asked our board and they approved. Can we realign it to what the law says? It really is not appropriate for us to seek the board's input and what we have been doing. And now all of our hospitals are able to initiate 5150s or release them. So people do not have to stay in waiting rooms. They do not also have to call the police to have and to initiate 5150. So we've significantly worked to decrease reliance on our law enforcement partners, though we appreciate our partnership with them. It was not appropriate. And we also helped and to designate other types of facilities across our county and providers and organizations to do that. So that's what the 5121 was. And we did this in concert with the work for SB 43. And we also adopted 5270. That's critically important. In short, that gives an additional 30 days for a person to, i.e., remain in John George. I'm sure you're familiar with 5150 allows you 72 hours, about 3 days. And then there's a 14-day 5250 that people can get. This allows us to do a 5270. So before you even seek a conservatorship, temporary conservatorship, we can apply 5250. The board did approve that. We asked for that because we thought with the expansion, we also wanted to give people more time to recover in John George. And so that's what that allows. For example, so now that the county has adopted it, any inpatient psychiatric hospital can utilize that to give them an additional 30 days before even have to get in conservatorship, which is very, very important because it allows you to really get a sense of their stability. And as people may be familiar, people participate in hearings. And sometimes if it is done too early, after, i.e. on day 15, they don't always win their hearing, meaning the treatment provider doesn't always prevail when they say they need to really stay in the hospital. But a person may clear up and participate in their hearing and be released and still may have issues. This helps us because they'll still have a hearing, but once they go through it, they'll have an additional 30 days to be held to really help support them. So it's really, we think, a very important and critical change, and really grateful to the board for their support and our advocacy to get us there.
Yes. This was big. Can you tell us a little bit more back to 5150? How is it different? Because a lot of us have families and support the community with this.
Absolutely. So I'm going to back up a little bit. So before, for example, grave disability literally just meant if I had a mental illness and I couldn't provide for myself to find clothing, shelter, food, basic personal needs. And many people felt like, for example, this is where the advocacy came from. It was a disservice because you may have been a person who's homeless and maybe have suffering because you don't have your medications, but technically they could be released or not placed on a hold, because technically if I'm homeless and I have a bridge to live under, I can live under there and I don't have to take my medications, my diabetes, my heart medications. I don't have to do that. And even if I believe, that voices are telling me not to do that, that wasn't a criteria that could help us to place them in psychiatric care. Nor was the ability to do substance use. Never in the state of California could you, for a severe substance use disorder, be placed on 5150. You just happen to be drunk or you just happen to be intoxicated or on meth. You couldn't use that as the basis to substantiate an inpatient psychiatric hospital. So that's the difference. And so now, and I've heard over the years, many people complain angrily and understandably that their loved ones died of substance use. It was because we when I say we, the entire state had no legal basis to hold them if they're suffering a severe substance use disorder. Now, under SB 43, we do.
Okay. Great news. Thank you.
You're welcome. And I do see a hand. I think I might.
Hi.
Yeah,
Yes,
there
I
was a
have
question.
I have a quick question.
Yes.
If your loved one who has serious mental illness is on an LPS conservatorship and they have a detrimental eye situation, can that conservator, I mean, my son now has canceled his appointment and it could affect blindness down the road. Can the conservator step in and make him go to
Absolutely.
that? Okay, thank you.
Absolutely. Mhm.
Thank you.
You're welcome. Absolutely.
Is the conservator the county? I'm just curious. Sorry.
Yes, it is not our department, but it's the social services agency. We work in partnership with them. So many of our clients or patients are conserved, but it's social services who holds the conservator's office in our county.
Okay.
Okay, so yeah, so those are what these slides are. And this, I won't go through all the detail, but this just gives you a lot of information about what we've been doing to prepare for this transition.
We're
A
stuck
lot-
on a summary page. Sorry,
Oh,
sorry.
you're stuck
Yeah.
on this summary page. Okay. So let me catch up. All right. All right. Have you moved forward?
Yes,
Okay.
now we do.
Thank you. I've got 3 screens, so I don't know where I'm driving. So I appreciate your patience.
No worries.
So again, this is same topic, SB 43, just some of the activities that we engaged in order to move things forward. And now, again, all of our hospitals are ready and able to take people and support them. And so this gives just more detail if you're interested. And so far, we've trained 174 people to have this to know how to do this SB 43 and all of our hospitals designated, and we have many different facilities as well. What is interesting is, and I know exactly the number and data, but I want to be really respectful of people because it's a small number. Believe it or not, we started in January 1st. The county's crisis system have not placed anyone on a hold based on the expanded criteria of SB 43. Now, we did more digging because we as a county, we get a record of everyone who's placed on a hold. And sometimes reporters are thorough, others are not, but we're doing a deep dive analysis. And what we did find when we dug deeper is those that were placed, there's less than a handful in Alameda County since January, they were all placed by hospital facilities. So that really does match what I was saying, that people are more ill. And it also is really affirming that our decision to make sure our hospitals were prepared and trained, as well as had the ability to drop and release and initiate holds, made sense because they're finding that people are coming through were medically ill because they came to them. So my guess, again, we're doing more drill down analysis, is it could be because of that substance use criteria. It could be acute substance use intoxication, or people are really not doing well, or medical reasons. So that's really fascinating. It's not necessarily what expected, but it is fascinating. But it's less than a handful, so I can't really give more detail than that. But what we do think is that a lot of the work that we set up, all these new programs, also may be helping to decrease the number of people in Alameda County who are placed on a psychiatric hold by training everyone, by having less law enforcement, by actually care court, by putting people into their treatment earlier on, may have also be impacted. So in other words, there are not as many people as Alameda County used to have over the last several years that need just to be psychiatrically held. They may have already been touched in some way. So we're continuing to analyze because, that's just what we do. We really appreciate looking and driving more specifically. If you look at the second bullet, we just want to see what are the impacts. We did build a new peer respite. We have other new facilities. Are they going there? They're getting diverted. Again, it's a good thing that we are not having people just psychiatrically placed on holds. And it is a good thing that we have people utilizing services, but we just want to make sure we're not missing anything. Now, our outcome is no different than other counties who've implemented. However, given our really great performance on, I don't want to say performance like acting, but we're doing really well with Care Court, getting a lot of people supported. That's why we want to look at that, because typically, because we are doing so well in other areas, to have more people in treatment, we would have expected more people being psychiatrically placed on holds across our system. But nevertheless, we'll continue to look at that. So I just started with, I mentioned Care Court, and I just want to remind people that Care Court was the new law that started, actually it was December 2024 that it began. And so this whole year, and to, the last year and a half, we've been moving through the process. Alameda County, we began it in October 2023. We had a really robust process. You see a lot of the logos of all the key partners. We're very, very well resourced with Indigo Project, who was our lead consultant, help facilitating a lot of this process. And it essentially gives a legal court way of getting people who are otherwise resistant to treatment into care. It is not involuntary, but it does go through the court system. You can civilly place a person into this process, or at least petition them. So here's a picture. I don't know if people remember, a few months ago, the governor came, and this is one of our facilities that we're building, and praised Alameda County for the great work that we're doing. So I'm very proud of what Care Court is doing, because comparatively, we far surpass most people in the state for having the most people and the most petitions coming through. So again, that's why we are analyzing, did that impact that there are less people placed on a psychiatric hold, because we're finding them and petitioning them more quickly through Care Court. And Care Court, even if when you go through your hearing, you don't officially become part of Care Court, the way Alameda has set up, you still can get into treatment, and we place you in treatment. One thing we are seeing, which is fascinating, is we're seeing a lot of privately insured people utilizing Care Court, which was not expected as well. So we're trying to link them back to Kaiser, because Kaiser is not legally required to do the work. We are required to assess them, but we're really not able to take on Kaiser patients because we're county, we're safety net. So we're trying our best to really link them back to, whether I said Kaiser, but it could be a variety of private insured. So that's also very interesting. There is a website. Again, this link does work. If you look, and this is, with our partners in the court, set up a whole website that helps people understand it. It's translated. We have it on our website as well. It links to the counties. There's a whole Care Court program within the courts that help family members and clients and petitioners understand what this is. So now, as of July 23rd, so now it is August 11th, more people have been petitioned. Our county has had 339, which was, again, why probably the governor took the time to come and visit us. We are very, very active in doing our due diligence to get as many people into treatment and to evaluate to see if this will work for them. And so this just shows kind of a snapshot of when those folks came in and out. And again, it stops in June 26th, but you can just see, if you're curious, when people came in at what time and the numbers.
This is people coming in or leaving? This just coming in, right?
These are people, yes, that have been petitioned. A person filed a petition to have this person go into Care Court. So is 339 of those that came through.
And how many were accepted? These are all accepted petitions?
I'm going to, wonderful question.
Okay.
I have a slide on that. And so right before we get there, often people want to know who is filing petitions. And so this is the breakdown. One of the interesting nuances is that Alameda County, I made the decision that we would file petitions. Other counties did not as a department. And so that also helped us. So in other words, we can see in our system individuals who are not doing well. And so we file petitions on their behalf. And so I sign every petition. I don't do the work. Again, experts and our team members handle that, and we work in partnership with agencies. But just this is where they're coming from. Believe it or not, we also had state hospitals or even prisons preemptively file a petition before the person was released. That we did not expect. So that's just a breakdown. If you're interested, here's also the demographics. We get a lot of questions of who's getting petitioned. This is a great example of why we have a health equity division. Their charge will be, and this is what we anticipated, why, for example, when there is a finite number of African Americans in Alameda County, why do they represent most of the care petitioners? So we will ask those questions to make sure there's nothing concerning, and to make sure that others also have the opportunity to access care, not simply by virtue of race or people's assumption of what they will need. So, but again, a majority of them, 82%, are between 25 and 59 years old. And then we have some transitional age youth and older adults in the program as well. So this is another snapshot. You had asked, where do they go? So this was through June. Again, this is a while ago. But of the 339 petitions, 317 met prima facie, which just means they were appropriate care court referrals. 15, I'll start with the first, 15 did not mean appropriate care court referrals. And we found that either they were not a resident of Alameda County, there was inadequate petition. So if it was a family member that may not have put anything that the court and the judge and the team could look at, we weren't able to move through the process. It doesn't mean that we don't follow up, but these are the status of those things. We had some people who we just couldn't find them. The petition was filed. We have outreach teams. We go search the county. We engage with partners, or it means or they needed a higher level of care. Some may have needed to be hospitalized. So we did not keep them in care court. We went to a higher level of care. Of the 317 that did meet criteria, at 89 agreed to services, 93. So this is important to note because it is, many people thought it was going to be involuntary. It is not an involuntary service. We do have a community conservatorship already in our county. We've been doing that for years. That's involuntary if you're conserved. Even assisted outpatient treatment is a higher level of care, but it is still voluntary. So is care court. So this just shows the breakdowns. So 148, even though they met face value, essentially being eligible, 148 petitions were dismissed. Now, we still give treatment or referrals to every single person that comes through that door. So even still, 339 people potentially referred back to services after the court determined, well, we cannot move them into care court, but our job as a county, and that's what we've been doing, is linking them to care elsewhere. So again, it could be all related to, again, I mentioned the SB 43, not as many 5150s. We just have more services coming on board and more ways for people to get care. And finally, this is a portion. So our budget is used to house people, and the state gave vouchers. And so this just shows you, of those folks that were referred, many people utilize housing vouchers and hotel type vouchers, and tier 4 meaning licensed boarding cares and other organizations, treatment beds, and rental assistance. And the law does require that any behavioral health bridge funding that we got from the state, they have to prioritize people with care court. And finally, so as I slowly end, and I know I've given a lot, I'm going to end with the BHSA. I've given a lot of information that I think will be helpful to you. So our new inaugural integrated plan was approved by the state in July, and we will give updates. So the integrated plan means now BHSA includes substance use. It's integrated also because when we submit our plan, they look at all of our funding. Before, when we submitted an MHSA plan, they only wanted to know what are we doing with those MHSA dollars. Now the state wants to know everything. So we'll give updates as things change. As I mentioned, any of these plans, we'll have to give an update, and they're for 3 years. So because some of the funding that we got to support BHSA was only one time, I mentioned the Measure W and things like that, we're going to have to go back to the state and tell them, we had this funding for these clients and beneficiary and programs. We no longer have them, for example, July 1st. Or if there are any substantial program updates, we'll tell the state. We're communicating with providers. We know that the services are going to change significantly. So we're also working on a system map to help people see, well, what is still here and what will continue. And the agency has also required or will require that those who receive one-time funding essentially create a plan on how they're going to sustain themselves or what they're going to do without our funding. So that is something unique. The county has never did that, but organizations will likely have to submit that to the agency. So this is partly of what I mentioned. It's just showing a snapshot of the money that we thought we would have, roll over extra dollars because it allows you any dollars that weren't spent, it lets you roll over for the next year. What we're using our unspent dollars is to carry over programs. That's what I mentioned that helped us not have to cut so much. It also shows, the investments, as I mentioned before, that we had invested about 35 now, but it says 31 million at that time because this was from May. And then we were estimating that we would also have to give to our health care partners an additional between 12 and 20 million, but looks like now it's 29. The African American Wellness Hub to construct a building because of those even very concerning outcomes that you saw, i.e. most of the care court recipients. We're trying to do a better job in Alameda County of more appropriately serving individuals who identify as Black in our community as well. That's what that is. And again, we bridged our prevention and early intervention providers. So this is just saying what we're using our money for. It's really to help sustain the system for BHSA. And finally, those construction sites that I mentioned, 170 some million dollars that we got. So here's an overview of them. And again, you will have these slides so you can feel free to look at them, but these are the types of services. The far left is the name of the program. It may change to something different. And it says July 1st, 21st. But this is just how we designate what it is. St. Regis, right in the middle, that was where you saw those, the governor standing in front. That was at the St. Regis site. That's where he came to visit us. These are the locations, the part of the areas. And I think if you can see, these are the rounds. That's not as important, but you can also see the organization that we co-applied with. And so, and I made the decision not to apply only as a county because typically our CBO providers can move more swiftly than county. And so for us, it was more important. It didn't matter that it didn't come right into my budget. It's going out to community, and i.e. La Familia, Telecare, Bax, Horizon, Alameda Health System can actually build those facilities in a much quicker pace. And as you see to the right, you can see what type of facilities. Adult residential, at the very bottom is a new one that we have never had, a geropsych, meaning older adults who need psychiatric care on an inpatient basis, but in a hospital setting. Very new. What we are seeing is our population are aging and are becoming more medically fragile. So we're partnering with our Alameda Health System, and it's going to be located at St. Rose. Very pleased at that. So that shows you the number of beds. There's also going to be a locked facility, just like Villa Fairmont. I think there was an earlier question about that. So we'll have another one, MHRC, and that is Depot Road, if you see that. MHRC.
Oh, that's the one, Depot
Yes.
Road, is that? Okay.
Yes, that's right.
When is that opening?
So it is being constructed. And so my guess is, I don't even have to guess. I'm going to move ahead. These are some early target dates that we have for some of these. So we anticipate there's a crisis residential treatment late 2027. When you see permit applications, it just literally means they have submitted to the state or the local cities to have final permitting, which will enable us to start the program. And so those things are TBD, and that's why there's not a specific date. MOSIN, crisis stabilization, 2027, BACS. Again, you asked about the location, and I'll move to the next slide. And again, we hope, depending on state licensing, the spring or summer at St. Regis itself, and I'll go to the next slide that shows Depot Road and such. Depot Road, we're looking at July of 2028. It'll be a large facility. It requires much more activity than the normal because it is a lot facility. So these are showing what those are. And you see, it says ASAM criteria, San Leandro Hospital. ASAM criteria is essentially a system for evaluating and scoring the levels of care needed for people who have substance use issues. And again, it fits with everything that I've mentioned, our dates. And just again, it's a blessing that we were able to focus on what our data was saying to obtain partnerships and buildings that would enable us to support people. But that's really what that is in terms of that. And then on the horizon, I'm going to stop and let you digest that again. We're also planning. Yes,
quick
please.
question on the San Leandro Hospital, this detox center and all that, is it voluntary or involuntary hold?
That's great. So an involuntary, I'm sorry, medical detox is a medical
That's like regular hospital then.
it's like a regular hospital. However, can a person be placed on a psychiatric hold at the and go there? Yes, because of SB 43. So SB 43 now allows a person to be placed on a hold, and the care provider or the emergency ambulance can say, wow, this person's on a hold, but they need to go to a detox. So first, let's take them to San Leandro Hospital. They go to the hospital and they are getting detoxed, and then we renew the hold potentially or reestablish something else, or we work with the hospital. So technically, medical care is voluntary unless a court intervened. However, a person can be at the same time placed on an involuntary hold. But again, we have to make sure we outreach to those folks so that we're not being illegal, because technically you can't force me unless I'm conserved or unless it goes through a whole legal process. So I hope that answers your question. It's a nuanced response. So
Yes, yes. So my loved one was in Villa Fairmont,
okay.
and they couldn't hold him, and they said he doesn't belong Villa Fairmont necessarily because there's substance use involved, mental illness with substance use, and we cannot hold him involuntarily. And then I found out that this facility, wherever it's built 2, 3 years out, might be able to do the job. Like he will be able to be held over there. That's why I wanted to understand which one it is and where it is and when is it coming. So is that if you go back a couple of pages, I think there's a whole list. I don't know if it was a St. Rose Hospital, San Leandro, or Depot Road. I think, yeah, it could have been a Depot also. Yeah, I think it's the Depot Road, BACS, Mental Health Rehabilitation Center. Target construction starts July 26, expected ongoing July 28. But did we lose her? I think she dropped out. Did she push the wrong button? She'll probably call back.
It looked like she was frozen, so maybe she dropped out.
Yeah. Yeah, she was not talking. She wasn't answering for a while. It was good. Lots of material to digest. So, but I don't know about the others, but there's one live experience that's living through Care Court program, and it all looks good on a paper, but when it comes to mental illness and treatment, everyone is a unique case and everyone experiences differently. So it's a tough road. I think we're gonna just wait a little bit. So while we're waiting, anybody has questions that she comes back, we can ask? Rosemary, you're talking, but you're muted.
I'm not totally clear on, when the funding law changed at the state level, and actually even the names of the departments, so that they're treating a lot of the money that used to go to mental health care is now going to substance abuse, right? And on one of those very beginning charts where it had the different departments and stuff, there was one for substance abuse, but there wasn't anything for mental health. But it seems like parts of it are absorbed in other departments of behavioral health, or how do you see what's the big change in terms of what were mental health dollars and services that are now gone because it's reallocated for substance abuse, the effect of it overall in the programs?
She's back.
I am back. I have no idea what happened.
We knew you'd be back. We knew you'd be back.
Thank you. I'm trying to see if I can reconnect.
Yes. I was trying to keep everyone entertained by saying if they have any questions, and Rosemary has a question for you. Marsha and I decided, we're not going to answer that. We'll wait for her.
Well, the good thing, I'm not going to turn my camera on. I don't know what's happening, but just in case my bandwidth, it looks like I got a notice from Xfinity. They are testing and they said you may experience outages, which is very helpful. But the good thing is I was literally at the last two slides. So it literally was something on the horizon. So I can just place them if I can to the chat. Just the slides that you see.
Sure.
It's really what I've been saying, that we'll be continuing to track and monitor progress. So I'm going to try to do that, and then happy to answer any questions.
Yes.
I don't know. Do you want to rephrase mine, Armene?
Oh, you did such a good job. You can do this. Go ahead, Rosemary. You got the floor.
Okay, previously, before the big changes at the state in terms of the names of the agencies, the funding for mental health, and that being decreased notably, and most of it going to the new focus, which was substance abuse. And even on your chart at the very beginning of your slides, about the third one in or something, where it showed all the different departments and colors, it had one there for substance abuse, but nothing that was specifically for mental health. Now, I mean, from the discussion, it looks like some of it still exists and I guess are under different categories, but overall, what do you see the difference now in what mental health services the county can provide?
I think on some of those programs that I have mentioned, for example, where I mentioned CalAIM, for example, and it looks like my video may be working, and I hope, I don't know why, but I'm going to be in, looks like San Francisco, so I apologize.
That's okay. Well, we'll take you anywhere.
I just left and went to San Francisco. So the CalAIM process did help in the sense that it also required for people who have more mild mental health needs to get care. So it made more accountability for the Kaisers, for the Alameda Alliance, for the health plans. to help. And so it is much more integrated across our system, more like a team approach. So it's not just relying on county behavioral health to do all the work. So those type of things did provide additional funding and help. That's a potential good thing. Unfortunately, the rates are low because, for example, it's reversed. Now the Alliance, who is the HMO for the safety net population, for people who have medical need healthcare and support, they contract with us to be a provider of services to their mild to moderate patients. And unfortunately, the rates are very small. So I'm having to add money from the state, add money to the program because we just think it's the right thing to do just to break even. So even though the state has created different lowered barriers to, for example, 5150, but it didn't come with new funding to provide support to people with substance use issues. Care Court, for the first year or so, we were operating on our own dollar. So we increased our full service partnerships by about 200 different slots without funding. The state caught up and said, we'll give you some funding, but that's been the challenge because as the number of Medi-Cal beneficiaries is going slowly down, and we know it's going to go very down, if I can say that as an adjective, in January because of the new federal laws. Counties and healthcare providers and hospitals are going to struggle to pay for all these new requirements and programs. And that's going to challenge quality because it's hard to make a choice. How do you maintain a program and not be able to pay your providers as much as they would like to be paid because the rates are so low? And we want to incentivize providers to do this work with us and to do all these new requirements with us. But it is a very difficult, precarious position we're all in. So I don't know if that answers your question, but access is more. So theoretically, the good thing is also the state created a types of forms where I don't know how much the population feels it, but we just use one screening tool between us. So they come in, we write it down, you give it to the hospital, they use the same language. So that helps people not have to repeat information, and we evaluate them. So again, I think some of the things can increase access and can increase that, but it did not provide the money to do it. And at the same time, it cut some programs and things. So this is a once in a lifetime amount of opportunity, like with the B-CHIP grants to build. That's wonderful. That was something many of us will never see again. But on the program clinical side, it is complicated.
So what are the main programs that were cut?
Well, under Prop 1, the types of all of the prevention programs were ended. And what we did in our county is transition them to more like early intervention, meaning if you have a diagnosis, you have the early stages and signs of issue, you can get support. That's a positive that we were able to actually, out of our $26 million of prevention, we were able to sustain about $18 million in programs, just change them a bit so that it's not just population health, it's more direct care. Unfortunately, the things that they used to do now no longer have a funding source. Many of them provided translations, transportation, meals to people. It was helpful to get them engaged to participate in treatment. And so we won't be able to pay for those things. So all those prevention programs have ended under Prop 1. Even with the bridge, most of them have ended. They've transitioned to something new. The other programs that, again, for the most part, we won't see a huge reduction until July of next year, because all the temporary funding measures that we've done this year were one time. And at that point, we will have less treatment programs, individual. We will have less ability to do outpatient services, less school-based programs unless someone else pays for them, because they were all one-time. Many of them were one-time funding sources.
So early intervention is still up to age 26?
Yes, and the state is even. I'm pausing because the state has, for example, first episode psychosis. We decided we would do that years ago. We already have it here, and it's a not one program does it. It's a evidence-based thing, and I mention that because the state early intervention now they're encouraging us to use that particular program up to end of life. We don't know that that would be as helpful for an 80 or a 9-year-old to have a first episode psychosis program, but the state is giving us more stretchiness. So yes, early intervention goes up to that amount ish, and the state's pushing counties to see if they can be successful with people way down the line. But for us, we really want to focus on true early intervention with folks. So.
Okay, we have a question from Armin. It says, I do have a question about housing and resident interaction management. So Armin, do you want to go ahead and ask your question?
Sure, thanks. Great presentation, and thanks for the job you're doing. Very needed. So once a patient gets assigned to a housing, it seems to be it's like a lot of chance or interaction management. Is there I know it's not that simple, but is there a better way to manage that? Kind of how would a person fit in that location or in that environment?
Yes. Well, so
Thank you.
housing for people with severe mental illness has evolved in the last several years. And I'm leading up to answering your question, so I'll be brief. We had a housing division within our department that we operated, and the housing slots and the housing care was wrapped around the treatment, meaning a treatment provider would actually be the one to help keep the person housed and stay housed. Now, within our agency, that has evolved. So housing now, although we fund much of it, or not much of it, I think we're now at about $30 million with additional funding and multiple millions to pay for different things. It happens outside of us. So what in a perfect scenario, once the person is housed, they should absolutely be connected to treatment. That is really the only way, in our humble opinion, that our clients and patients are most successful. And it shouldn't be to chance. But there is a different approach now where it's coordinated entry, meaning even we will have to call a number to access our own slots that we pay for. So it's really we are really aggressive to work with our housing partners, and they're within the same agency. So there's a lot nexus there, but it really is you have to be very intentional so that it doesn't fall to chance. And that, once that person is identified in terms of a placement, whoever the provider is shows up there, meets the landlord, helps with the vouchers, helps them stay current. If they're having a mental health issue that could make them lose their housing, we stay on it really fast. So it is a little bit more complex because we don't operate and run it ourselves anymore. And it really is only as strong as the coordination between housing, which is outside of us, and our behavioral health network of providers and the county behavioral health.
Thank you.
You're welcome.
That is a good answer, but it is very difficult because a lot of time, and I'm talking about my own personal experience, right? In those housing situations, substance use gets in a way. Everybody
Yes.
says that you can't use it in a house, and then people use it, come back, and it's the unwritten rule. They won't kick them out, but it impacts everyone. People get ill at different times, different situation, different triggers. So
Yes.
it's pretty bad. And then the medical, they don't always agree to go. And then I've been told, because now I'm talking from care court perspective, right? They do They run a great job, by the way. I've been involved because I'm personally involved, and you signed one of those because my loved one came through Alameda County. And uh, initially, and even now, I have nothing but good things to say. The problem is, every case is very unique. And
Yes.
these are SMIs. It's truly very difficult cases. And it seems like when you run this program, their hands are tied, okay? They can't do anything. The law is stopping them to help. And it's very difficult. So one of the questions I have is, you said community conservatorship. Can you please tell me more about that? Because Alameda County, and a couple of times I approached, they said probably won't be conserved. And right now, my loved one needs protection from himself, is the bottom line.
Yes.
And but conservatorship seems to be out of the equation.
Um, yes. Well, I mean, you said so much. It's just textured. The things that you said. I think I'll just, to respect time, I'll briefly say that you have identified an issue that we also have identified with just substance use alone, for example. Because what we found is you can't have a recovery residence and say they can't make any mistake, and then they lose their housing, and then they become homeless, and then the cycle continues. So that's why some of the construction that we've identified will be not that we want people to use while they're home, but we also have treatment, and we also have detox, and we have readiness. So we're building in a much more practical. It's not even a judgment based or not. It's not about that. It is that we are losing more people because they get kicked out and lose their home, and that's that part. And in terms of the way that the law is set up, and that is a big fear. So I'll just acknowledge our biggest concern is that Alameda County has put in so many programs to prevent people from worsening, to wrap around them, that now these programs that are pushing services downstream inevitably will be what you're mentioning, that people are not severe enough to qualify for conservatorship, or they're not severe enough to have X, Y, and Z. And so we're really concerned about the trend. Even care court, there's just a specific type of person who can have it, and it is not truly involuntary. So for us, we're trying to figure out different ways, strategies to not go where this tide is moving, to mostly focus on when people are really down and out, because you can't recover as well if you wait too long to intervene, i.e. if you don't have enough programs that can support. So we're trying to build, and you saw those examples on the B-chip slide, and I actually tried to put something in chat, but that went dark too, so I wasn't helpful. But I will send you my slides, because the types of
Yes.
programs that we're targeting, and again, thank goodness that they're aligned, we hope will help exactly what you're describing. Wherever the person's at, if they need to be locked, they'll get the care they need. And now it allows us to provide care to people, substance use or anything else. So, but we have the same opinion, and with some concern based on what we're seeing. But
So Alameda County, with the Villa Fairmont and the average stay of 3 months, we really don't have anything that's a longer term, 6 months to a year conservatorship. And it's very, very hard to get a referral to go outside of Alameda County. So what is our strategy on that area?
well, the additional beds, that we're building, and I want to make sure I'm correct, and I know we're at time. We're trying to open 83 additional locked beds. Part of why the throughput, meaning the time people stay and moved, was out of necessity, but also we did find that we do have people who are there for much longer, many, many, many months. But the average is now more connected to how they're doing, but we think we need more. So that's just the honest truth of it, that just like with, if you had a hospital and all of the patients never left the bed, no one else would get served. So it's unfortunate they have to look at, well, are they able to be stabilized? Well, with additional 83 beds, that question will be less necessary, because we'll be able to actually have people in those beds and can have more specific service. And right now we're trying to determine what type of specialty that Depot Road, for example, might have, because Villa Fairmont serves a certain population. We may want to serve a slightly different, nuanced subset in a lock unit. But yes, you're actually speaking to what we are concerned about, which is why we targeted building more, so that people really do have a little bit more luxury to be where they need to be.
Thank you. Thank you. I'm not going to dominate. Any other questions from anyone? We're running, actually, we're 3 minutes over. And then thank you, Dr. Tribble. So for this, you can tell, so much needed conversation.
Oh, you're most welcome.
Anyone else wants to unmute themselves, ask a question? Last chance. We'll take probably one more question. Okay, so the recording will be shared on our website, and we will get the presentation, and that will also be posted with the recording. And
Thank
this
you.
is always priceless. We look forward to seeing you next year. Thank you so much for your time. And some people may say it's your job, but we're honored to have you here every year, or at least once a year. So thank you. I applaud your
Thank you.
efforts. Thank you.
Thank you. Thank you so much. And I apologize for being now in San Francisco. And sorry, I probably used those 3
That's
minutes. So
okay.
thank you for your questions, and I appreciate it. I see it as it is my service, and it's much more than my job. So thank you for that and inviting me. And I do think I may have sent the slides already. So please let me know. I will resend them. Thank you for confirming.